Welcome to From Literature to Bedside. Tonight, acute colonic pseudo-obstruction, Ogilvie syndrome, the colon that dilates to bursting with nothing blocking it, and most often in our postoperative patients. Acute colonic pseudo-obstruction is massive dilatation of the colon in the complete absence of a mechanical obstruction. It is a disease of the hospitalized and postoperative patient, and its danger is simple. A colon that keeps distending will eventually become ischemic and perforate. Two decisions carry the case: excluding a mechanical cause and judging when a distending cecum has become dangerous. The mechanism is autonomic. A relative excess of sympathetic tone or suppression of the sacral parasympathetic outflow from the S2 to S4 leaves an atonic distal colon that behaves as a functional obstruction. The dilatation classically extends to the splenic flexure, the watershed between the vagally innervated proximal colon and the sacrally innervated distal colon. Surgery, sepsis, metabolic derangement, and neuroactive drugs all tip that balance. It is overwhelmingly a complication of serious illness and surgery, typically in men over 60. The commonest triggers are orthopedic surgery, hip and spine, pelvic and cesarean surgery, which accounts for about 92% of postpartum cases, and cardiac surgery. Trauma, sepsis, and cardiac disease each contribute to around 10%. In this setting, new distension is pseudo-obstruction until proven otherwise. Layered on top are the correctable precipitants, and everyone is a target of first-line therapy. Electrolyte derangement such as hypokalemia, hypomagnesemia, hypocalcemia, drugs such as opioids and anticholinergics, above all, the daily companions of the surgical patient, and immobility ventilation with metabolic stress of major surgery. Clinically, progressive distension with tympanitic abdomen, pain is often modest and bowel sounds may be present. The essential step is to exclude a mechanical cause of obstruction, which might include volvulus, ischemia, and other causes of obstruction. And CECT is the investigation of choice, showing diffuse dilatation to a transition at the splenic flexure, no mechanical lesion, and letting you judge the cecum and the bowel wall. The reason we intervene is the cecum. By Laplace law, it bears the greatest wall tension, and the risk of ischemia and perforation climbs once the cecal diameter passes 10 to 12 centimeters and when the distension has lasted for more than 6 days. Spontaneous perforation occurs in 3 to 25% of cases, and when it does, mortality reaches up to 50%. Those numbers justify escalation, not patience once the cecum is large. Management is stepwise escalating ladder. Exclude a surgical abdomen, treat conservatively with correcting precipitants, then neostigmine, colonoscopic decompression, and finally surgery. A patient with peritonitis, ischemia, or perforation skips the ladder and goes to the theatre. For the stable patient, supportive therapy for 48 to 72 hours is the first line and resolves 77 to 96% of cases, and median resolution around a day and a half. That means nil by mouth with nasogastric decompression, correcting potassium, magnesium, and calcium, stopping opioids and anticholinergics, treating sepsis, and mobilizing the patient. Track the cecum with 12 to 24-hour radiographs and escalate if it fails to improve or reaches 10 to 12 centimeters. When conservative care fails, the cecum is critically dilated. Neostigmine is the pharmacological treatment of choice, and it has the best evidence of anything we can do. In the landmark Ponec randomized trial, a single 2 mg intravenous dose produced prompt decompression in 11 of 12 patients, that is 91%, versus none on placebo. Pooled response across studies is 85 to 94%. Give it well. 2 milligrams intravenously over 3 to 5 minutes. Patient supine on continuous cardiac monitoring. Observed 15 to 30 minutes with atropine drawn up at the bedside for symptomatic bradycardia. A second dose rescues many initial non-responders. Mechanical obstruction and perforation are absolute contraindications. Bradycardia, bronchospasm, recent myocardial infarction, and renal insufficiency are cautions. If neostigmine is contraindicated or fails, colonoscopic decompression achieves initial success in up to 95%. But it is demanding in an unprepared fragile colon. Perforation risk around 2%. Procedural mortality around 1% and recurrence near 40%. The technique matters. An experienced endoscopist, minimal insufflation, careful advance to the distal transverse colon, and a decompression tube with polyethylene glycol afterward to reduce recurrence. Surgery is for perforation, peritonitis, ischemia, or failure of everything above. Because operating on an ischemic or perforated colon carries a mortality up to 44%, the aim is to intervene before that point when escalation is failing. Without ischemia, a tube cecostomy is the least morbid definitive option. Established ischemia or perforation mandates resection. For our postoperative patients, 3 practical points. Anticipated it after hip, spine, pelvic and cardiac surgery, and in the ventilated or septic but still get the CT to exclude mechanical disease. Prevent and treat the reversibles early, opioid sparing analgesia, aggressive electrolyte correction, mobilization, and measure the cecum and watch the clock. Escalate at 10 to 12 centimeters rather than waiting for 6 days of distension. A candid appraisal. The pyramid rests on a single small randomized trial, that is the Ponec trial with 21 patients. Almost everything else is case series and consensus. The caecal threshold predict risk imperfectly, so trend and clinical state matter more than any one number. And given its evidence, neostigmine is arguably underused. Earlier use in the monitored non-contraindicated patient is reasonable. So to synthesize, pseudo-obstruction is massive colonic dilatation with no mechanical cause. Confirm that with CT. A cecum beyond 10 to 12 centimeters or distension beyond 6 days is the danger line. Treat conservatively for 48 to 72 hours, correcting electrolytes and stopping opioids. If that fails, neostigmine, the one intervention with a randomized trial behind it, then colonoscopic decompression and surgery for failure, ischemia or perforation. Recognize it and correct the reversibles and escalate before the cecum gives way. Thank you for watching From Literature to Bedside. I am Dr. Gautam Krishnamurthy. Until next time, watch the cecum and act before it bursts.